I think we'll begin. We've got a great presentation for you this afternoon, and we want to get on to it. So welcome to today's Circle of Excellence presentation. For those of you I haven't met, and I think I do know most of you on this call, I'm Molly Stearns, and I'm the Chief Development Officer here at Overlake Medical Center. And on behalf of our whole foundation team, we want to thank you for being with us today. I want to start again by also thanking you for all you do for Overlake. Without you, we would not be the world-class institution that we are today. Your support matters so much, and it helps us continue to meet the needs of our Eastside community, both at the primary and specialty care level, and you'll be hearing more about one of our specialty care service lines in a minute. And as you've been reading, healthcare is changing at a rapid rate. Now more than ever, I mean, we just can't thank you enough for engaging with us and continuing to support us in our work to provide the very best care for you and other members of our Eastside community. Our CEO, Mike Marsh, is unable to join us today, but he sends his very best. He always looks forward to these Circle of Excellence presentations, and he'll be back with us next time for sure. But before we get started, just a few logistics. And I think most of you are pros at these virtual meetings by now, but just in case, you're all on mute. But there'll be plenty of time for questions at the end. If you have a question during the presentation, put it into the chat function, and we'll be monitoring those questions here in the office. And thanks to those who did submit questions ahead of time. We'll make sure that they are answered. And if not, during Dr. Likosky's presentation, we'll make sure that we'll pose them to Dr. Likosky at the end. Today's presentation, as you all know, features on the Eastside Neuroscience Institute. The Institute was formed under a joint shared vision of integrating neuroscience expertise from Overlake and Evergreen Health in order to provide comprehensive best-in-class care in this area for patients on the East Side. Overlake and Evergreen have also come together in the area of cardiology to, again, same mission, provide the very best, most comprehensive care to our East Side patients. By coming together in these two areas, our two institutions can better assess joint needs and respond to them better for all of our benefit. Some of the services, and I know Dr. Likosky will speak more about this, are offered at Overlake, some are offered at Evergreen, some at both institutions, but we provide them together under joint leadership. While we're an independent hospital, as is Evergreen, Overlake is always interested in partnering with organizations that can bring better support and services to our Eastside patients. Many of you recall that in 2020, Overlake launched an affiliation with Seattle Cancer Care Alliance, now Fred Hutchinson Cancer Center, and this has gone very well. As we will continue to report on all of these different partnerships and all of our other programs, this is all done with your help to make us better. Today, Dr. David Likosky is here. You're seeing him on screen now. And he serves as the executive director of the Eastside Neuroscience Institute. He will talk more about the program and tell you more about how our patients and community are benefiting from this combined expertise and where some of this will be going in the future. Dr. Likosky is a board-certified neurologist and internal medicine hospitalist. He received his medical degree from the University of Washington and University of Vermont School of Medicine, and completed residencies at the University of Washington and University of Arizona Medical Center. He specializes in stroke neurology and co-founded the Neurohospitalist Society, which is pretty interesting. I didn't know that, David. He's been in practice on the East Side for more than 20 years. We are so lucky to have David as our partner. I think you'll appreciate what I had just said after you heard him speak. So without any further ado, David, take it away. And thanks again for doing this.
Great, thanks, Molly. I appreciate the kind introduction and words. And please, if you could let me know, I'm going to start my slides ideally. Can you see those?
Not yet. We're seeing you, but not the slides.
Okay, let me try switching screens then.
Okay.
Oh, it says I'm sharing them. Give it one more try, and then I know you have a copy.
Yeah. Otherwise, I was going to say we can help you.
Yeah. So you're not seeing my slides there.
No. Why don't we let me get Katie to get them up. She's probably already working on it as we speak.
Yeah, that sounds good.
Okay.
Seems like there's always a different twist each time to something like this. Perfect. Thank you. Let's see if I can, yep, and I can take control, which as a physician just feels right. Great, so thanks for the opportunity to speak today. I'll go through some things over the next 20 minutes or so and talking about really the goals of this Eastside Neuroscience Institute. And it was said, well, you know, the real endeavor here is to work together to deliver something that we have really tried to deliver for many years now, but has been difficult for one hospital or the other to do, and a good reason for why Evergreen and Overlake have come together in this kind of way. My background is in neurology. We'll talk about the different elements of this Neuroscience Institute and some of where we're going. Oh, I just had it disappear. I don't know if you did as well.
We did, but I'm sure that Katie will have it back in a second.
Great, thanks.
She's working on it. You know, it's just always something, isn't it? Technology. I mean, we do so well. Here we go again.
I think the key is that it's something different each time.
That's right. There
All right,
you go.
So the outline of what I'll talk about is give some of the context and history for neuroscience on the East Side. As has been said, you know, I've been a physician here on the East Side for about 22, 23 years, and so have really seen, as I'm sure many of you have seen, the evolution of the population here and the level of sophistication of the medical care that is both provided at Overlake as well as is expected to be provided. I'll highlight a selection of some of the clinical areas. I appreciate some of the questions that were submitted a bit ago as well, and I'll try to hit on those as we go through things, but we'll have some time at the end to talk about those as well. And we'll be talking about future steps and what we can expect here on the East Side and in the field as well. So if we look at neurology, neurosurgery, and spine, these are the components of our institute. And it really covers a pretty broad range. And so neurology, as neurologists, we take care of everything from the very common, so headache, to the less common things, but more devastating things, stroke, seizures, you know, things that can be pretty benign, such as weakness, or things that can be really serious causes of weakness. And so neurology is sort of the foundation for a lot of what we'll be talking about today. And we have a large group of neurologists now. On the neurosurgical front, neurosurgery really envelops a wide range of things as well. And we have neurosurgeons that specialize in really all of these areas. And so everything from brain tumors to bleeding stroke to functional neurosurgery, which is in the ability to actually change function using devices. Ranges from trauma to aneurysm care, and so those things that can cause bleeding kinds of strokes. Spine surgery also folds under neurosciences, and the spine surgery we provide here is both from neurosurgeons as well as orthopedic surgeons. We'll talk a bit about back pain care as a whole, but same sort of thing. Spine surgery also really has a pretty broad range to it, and it can include things from minimally invasive surgeries for disc disease to tumor care, trauma, and so we do see some trauma at Overlake as well. I thought it was helpful to take a look at the area that we cover. So when you look at evergreen in green here and overlake in blue here, and sort of the area that is an overlap between. This used to be a big area with not a lot of people. It's now a big area with a lot of people. And so we really are able to cover a lot of territory and have really seen as I said before, the level of sophistication and expectation for the patients here, all of us who really don't want to have to travel to other centers for the care that we should be able to receive locally. It's a project that we've been working on for many years. So I remember I was at this meeting in 2006 where both Overlake and Evergreen spoke to a lot of our community physicians and tried to strategize how we would move neurosciences further on the East Side. And so these conversations have been going back really quite a while as we've tried to develop this kind of institute. And we finally gotten to the point really where we've been able to pull it off, which is super exciting. So what does this allow us to do together? Now, both hospitals, Evergreen and Overlake, have had strong basic services around neurosurgery, neurology, and spine, but we're now able to bring that to a higher level and then expand what we're able to do as well. And so we'll sort of define the basics as neurology, neurosurgery, and spine clinics, as well as surgeries. We're able to expand the trauma and emergency coverage that we're able to provide. And now we're able to move well beyond even those, what you would sort of call basics. I mean, the reality is this is neurosurgery, it is brain surgery. And so the basic really isn't all that basic. And I'm sure if any of the neurosurgeons were on the line, they would agree with me. So as we move beyond the basics, what I'll do is talk about some of the areas, and really, honestly, this is just a selection of some of the areas that we've been concentrating on. The reality is we have groups that are of a size now where we're really able to concentrate in a lot of different areas. So we have, more than I think 24 neurologists. We've got 4, 5, 6 neurosurgeons. We have neurocritical care physicians. We have orthopedic spine surgeons. And so we really have a large group where we're able to really start to concentrate and specialize in multiple different areas with docs who are well-known locally, regionally, nationally for the care that they provide, and honestly, in some areas globally. And so we really have a powerhouse of provider talent that we've been able to attract based on the vision for what we do. So what I'll do is start by talking about seizures and epilepsy treatment. This has been an area of focus at Overlake for many years now, and it really has just continued to increase. One thing, as we talk about seizures, which are the abnormal electrical signals in the brain, which may cause a change in consciousness or may cause abnormal motor movements. And then epilepsy, which is the condition where one suffers from seizures. There's a lot of advances that have been made. So not only from medications, which used to be just a couple of medicines that we had, to really more than a dozen medicines that we use for seizures, but also the ability to intervene surgically. And so the ability to go in and either stimulate an area of the brain that will help suppress seizure activity, or go in and really remove a small piece of the brain that may be causing that seizure activity. And so what we'll see here in just a minute is that we're moving from sort of talking about seizure treatment and epilepsy to really having a robust, comprehensive epilepsy program. And then I'll talk in a minute about some of the services that we provide now and are building toward providing too. Now, this next slide is really more of an attempt to show just how complicated this area is. And so there are different phases of treatment for epilepsy and seizures, and I don't expect you to read all these. There's phase 1, phase 2, phase 3. Some of this was largely an excuse for me to say laser amygdalohippocampectomy, which obviously I did not even say very well just now. But this really is that kind of brain surgery where we are using lasers and are actually performing that procedure now. Now, it sounds kind of cool, but the reality is the newer techniques allow us to intervene in a much less minimally invasive way. And so seizure surgery years ago used to be a very invasive procedure that had prolonged recovery times and left people with significant damage as a result of that. We're now able to actually, through sophisticated imaging and sophisticated surgeries, target very small areas of the brain to treat, which has much less effect on, say, speech. Some seizures arise from the speech centers. And so as you might imagine, you can't just take out a significant portion of a speech center. You want to really be able to say, okay, this 2 mm spot is the one that we want to be able to treat. And so these are the kinds of things that we're able to do. And so one of these things that we do is minimally invasive tissue ablation, or LITT therapy. So that's a laser interstitial thermal treatment. And this actually is a map that is in motion. Let's see if I can click it. No, but no worries on that. What this is a functional map that the neurosurgeon uses to through a small hole here. And so to orient you, this is sort of a cross section of the head, and this is the back of the head. So the occiput and the eyes are here, the nose is here, and the surgeon puts a small catheter in, and you can see in this sort of picture here, being held in the hand, just how small that is. And you can see in the picture on the bottom right, sort of the path that takes. And so what we're seeing is that catheter go in and very carefully actually heats up the area of brain there and damages the part that's causing seizures without causing heat damage to the other parts of the brain. And so an extremely sensitive, precise procedure, which in the past either would be something we couldn't have done at all, or something that would have involved removing, a big portion of the skull, going in and doing a major surgery. And so exciting things that may sound sort of futuristic, but we're actually starting to do now as part of our comprehensive epilepsy program. To change gears to some actually even more common conditions, we offer comprehensive care for many complex diseases. And what I'll do is I'll take one of those, which is Parkinson's disease, as an example of comprehensive care. And so what I mean by that is it's not just care where you go in and see a neurologist and talk about the disease, maybe get a medication or two, and then see you in 6 months or a year. It's really providing care for the entire patient. And so Parkinson's disease is a chronic degenerative disease where you can see this progression from initially trouble walking to then needing a walker, and it can progress beyond that. And has really a lot of significant effects cognitively, and introduces any number of different kinds of problems as a result of that as well. And so we have a center that doesn't just treat with medications, but goes beyond that. An example is the research that we provide. And so we are able to enroll patients in multiple trials. And so we're a very large trial center. We actually have 5 different movement disorder physicians, so fellowship trained in Parkinson's disease management. They work with our surgeon to actually do deep brain stimulation. And so this is the idea of functional neurosurgery, where you actually implant a pacemaker here. The wires go up under the skin and then through a small hole, again, sort of targeting a very small area of the brain with a catheter. And then that can be programmed, much like kind of a pacemaker for the brain as a way of thinking about it. And so that treatment is something we've been offering and have been offering more and more because of its ability really to impact the course of this disease. We do that as part of a team. And so one of the cool things that we do both in Parkinson's disease, and then this is in brain tumors, so another very complex area of care, is we get large teams of docs of multiple specialties together who are able to really talk through these complex cases, bounce ideas off of one another, look at images and decide together, well, here's the best way to treat, in this case, this tumor. So this is the tumor board that we have. So the docs will get together, and in this case, I think we had 30 different clinicians talking about what's the best way to treat this specific patient, because as I'm sure you can appreciate and know, we're all different, and each of these cases has different elements to it, and all of our data is really increasing and getting more complex over time as we're able to offer higher and higher levels of care. The other thing I learned from this is, if you look at Dr. Gwynn here, if you put your camera up, it gives you more of a noble look than if you have your camera down like I probably do now. So another lesson in how to use Teams for me. I will switch gears a little bit here and talk about stroke care, which has been a major focus of what we're doing at Overlake and across the East Side as well. The care for stroke has really dramatically changed over time. Some of the keys to stroke still remain how quickly one is seen and cared for. And so our system of care is extremely important in how we get patients to the hospital as quickly as possible. This FAST scale is something that we use to help identify stroke. And so that is a way of assessing people who may be having stroke symptoms. And so that's F is face drooping. A is arm weakness. And so you have someone hold their arms out in front of them. And if their arm is starting to drift, then there's concern for a stroke. If they have trouble with their speech, so if they're slurring their speech or are hard to understand, that's another concerning sign. And then the T is for time, to call 911, not to drive to the hospital even if you're close by, but to really get an ambulance to see the person immediately. If any one of these is positive, then we call that a positive FAST test and is a significant concern for stroke. We treat all kinds of stroke, and so they all go under the category of cerebrovascular care. And strokes can be bleeding, so a blood vessel can burst, or they can be not bleeding, so that's typically caused by a blood clot or a closing of a vessel, most commonly due to hypertension, diabetes, or high cholesterol. We also treat aneurysms, which can commonly bleed, and have a full setup to do that, which I'll show you here in just a minute. And really just to emphasize again that seconds do matter in the care of these diseases. And so millions of nerves may die within seconds or minutes, and we now have the ability to treat those. And so when I started in practice, it really was literally just, give an aspirin, but we have now moved well beyond that. We play an active role in the King County stroke system. This is one of our typical neurologists here with a reflex hammer in typically heroic pose. And we've done research projects with really King County and EMS to how we develop our system of getting patients to the hospital as quickly as possible. We offer what is called thrombectomy, which is a relatively new technology, which actually allows us to take a catheter and go into the blood vessel in the brain and remove a blood clot, which may be blocking oxygen and blood flow to an area of the brain, and have seen really tremendous results. And so we're able to do that extremely quickly at the hospital and make huge differences in how patients do, all the way from, patients who in years past would have either passed away or been really devastated by their injury, to at times patients who have essential resolution of their symptoms. And so it's just an earth-shattering change in what's happened, and we'll continue to see that continue to progress in a positive way too. The procedures that we do are done in this kind of room. And so in these rooms, we have what's called a biplane. And so as you can see, it's a large sort of semicircular device. It's essentially a fancy CT, which is a fancy X-ray machine that allows you to see in 3 dimensions. And so if you can sort of picture the different pieces of that machine moving in 2 different directions, it allows the patient who's on the table there to lie there and have their brain really mapped closely by a team of dedicated techs, nurses, surgeons who are able to look on a screen, and here's what this looks like as we do this, and see the blood vessel. And so this is Dr. Khan, who's one of our neurointerventionalists based here at Overlake. And this is a carotid artery, and I'll show you an example here in a second, where he will inject dye into one of the blood vessels, much like they do in cardiology for a cardiac cath. And really, you can see using that X-ray where the blood is going to the brain. And if a vessel is cut off, you realize that there's something there, a blockage, that you then remove. The other thing that we treat are more complex conditions, like an arterial venous malformation, or AVM. And this is kind of a cartoon showing you what these look like. And so this is a connection between an artery, which is red, and a vein, which is blue. Arteries are a high pressure system. Veins are a low pressure system. And so the direct connection between those results in a weakness, which is likely to bleed at some point, depending upon their characteristics. Really, all of this is plumbing. And so it's pipes of different thickness, and thick here on an artery side and thin on a vein side, and the pressures that are a result of that. So this is, I'll show you a film here in a second. We have a patient who came in with one of these situations, and this is a catheter that is threaded through the artery to the vein. And what we do is we actually obliterate that. And so what used to take a big open surgery, again, where you would remove half of the skull to get at this, or a significant piece of it, we can now go in through a small just puncture in the groin and access the blood vessel and go up. So if you look at what that looks like radiographically, we end up with something like this. And so the blue circle, beautifully drawn by one of our surgeons, is around that AVM, and so that arterial venous malformation. And if you can sort of see it, it's basically just a mess of little arteries and little veins which connect, which in this patient had bled. And so they brought the catheter up through the main artery here and into this and clotted it off with no ill effects to the patient at all. And so you can see on the image on the right, that area of blood vessels is gone. And so you can sort of make out, if you look closely, that there's some catheter and some material in there that is used to clot that off, but that any blood flow there has essentially been stopped. And so dramatic result, patient went home the next day from this procedure, what previously would have been either a potentially devastating bleed or could have been a big open surgery. So that's an example of some of the cerebrovascular work that we do. I'll move to something more common. I'd say it's mundane, but for those of us, and I'm sure myself and many of you who have had back pain, there's nothing mundane about it. Back pain is a very common condition. 65 million people in the US in one study recently had back pain, and about 8% have chronic back pain that may limit activities. Mostly, the sixth most costly condition in the US. And what's important here, I think, and probably most important, is we treat the continuum of back pain. So what you don't want to do is say we just treat with spine surgery. What you really want to say is we treat back pain. And the bulk of back pain treatment should be non-surgical. And so we have teams of rehab doctors, so physiatrists. We have allied therapies, which includes physical therapy, occupational therapy, who can help with strengthening exercises, which are really the linchpin to restoring mobility and minimizing recurrent episodes of pain. But also, we then offer, which goes to be a minority of patients who go on to need surgery for degenerative disease or other causes of pain. As I did mention before, we have neurosurgeons and orthopedic surgeons who work in partnership in this kind of area. Each brings sort of a different point of view and has different things that they may be more comfortable with or better at. But the nice part is we have, again, and you've heard the theme, I think, through things, a collaborative approach to this kind of care. And so we have the teamwork and the different groups between the therapists, rehab docs, and the different specialties of surgeons, and when necessary, oncologists and other groups, to be able to really treat patients well thoughtfully and thoroughly, and really with a minimal of invasive care or surgery, only if absolutely indicated. There have been and will continue to be a lot of advances in spine surgery. A lot of this is around devices. There's a question about, are there advances in the treatment of spinal stenosis? And not that I know of in a specific kind of way, but I think we're getting better at doing really minimally invasive surgeries, which is an area that all of our surgeons specialize in, so that, you see sort of these scary kind of pictures of significant hardware, and that's the bright pieces in here. But the vast majority of what we do is not that kind of surgery. I think the nice part is we have providers, physicians, surgeons who are perfectly capable of doing that kind of surgery, but also, and this goes really across the group of docs that we have, really emphasize that their goal is to avoid surgery. And so that's the vast majority of what we do. I'll wrap up with the next slide and open it up to questions as well. And I wanted to talk just a bit about why the neurosciences are such an important area, and really what the future holds. And I think they're important because obviously, the brain is the seat of who we are. And I think there are a few things that are scarier for any of us than thinking about what, brain damage might do, no matter what the cause might be. But it's also an area where we historically have not known very much. And really, we now know a lot more than we used to. And we continue to see that. And as you've seen in some of the slides that I've shown, our ability to intervene has dramatically changed over the past few years. And we'll continue to do that. And so we want to make sure that we stay abreast of that technology, that we are able to have a team that is proficient in using these newer techniques, and have the resources to be able to do so. So not a lot of these things that we do are very simple, and all of them come with sort of the attendant research involved, with the devices that are involved, from that laser device that I showed, with some of the imaging that we talked about. And as we understand things better, the indications have changed too. So we're starting to see that this functional neurosurgery that we talked about, say for Parkinson's disease or for epilepsy, may have applications really in other diseases such as depression, anxiety. And so we're starting to see this brain implant, as you see the headline there, which is really a pacemaker placed in the brain to help treat resistant depression. And it's been used now to treat resistant anxiety. And so we'll be well positioned once this hits more mainstream to be able to treat patients in that kind of way. It involves things like having really advanced imaging. So this colorful image here is called tractography. And so this is an MRI actually which allows you to see the pathways of different nerves as they go from the brain down to the rest of the body and back, and allows us to really target very carefully what kind of interventions we may make. The top right here is a CAT scan, which allows you to see arteries. And so this is this sort of large, on the left here, red ball there is a large aneurysm. And so allows us to visualize exactly how we might approach that. On the bottom right here is a stentriever, which is a removal system for taking clots out in the setting of stroke. And so this is a clot in an artery here, and that sort of cage mechanism there actually ensnares the clot, and we are just able to pull the clot out from an artery that is feeding that area of the brain. So really amazing things that we're able to do. And one of the most exciting things I think about neurosciences now is that we're just kind of scraping the surface of what we're able to do, and the things that we anticipate being able to understand better, treat better with medicines, treat better with surgeries, are really the motivation for developing this Eastside Neuroscience Institute, to being able to attract the caliber of docs that we've been able to. And obviously the attraction is places like we have here at Overlake, which is a wonderful place to practice, and so supportive both from a community and from the hospital itself in really achieving these kind of outcomes and treating this kind of diseases, which range, as we've talked about, everything from back pain to depression to spinal cord tumors to brain tumors. Really covers a broad swath of what's out there. So I appreciate your attention. I'd be happy to open it up to questions now, and any areas that I can help address further or help clarify. I'm more than happy to.
That was fantastic, and I think I've got to get my Dr. Gwynn kind of noble kind of setting to this Teams camera. So thanks for pointing that out too, David. You know, we're a small enough group. If people would rather just take yourselves off mute and ask your question directly, that would be completely fine. The questions that were submitted ahead of time, I think you did a great job answering. I sure have learned a lot. Thank you. Anyone else want to follow up with any additional questions? Or there is just a lot going on. Wow, I think you stumped the band. Oh, here comes one.
Yeah. Good morning, or good afternoon, actually. I feel like it's just been my morning, but so interesting. I did not realize that with depression that you could put a pacemaker in. I'm wondering how you regulate that. I don't know if I caught that or not.
Yeah, no, great question. This is really just coming out now. One of the things that's a little bit funky about the way devices are regulated is that the approval process for a device is largely that it's safe, more so than whether it's effective. Whether we use that device is based on whether it's effective. So from a regulatory standpoint, the devices may be available, but we wait to use them until we make sure that they actually do what we want them to do. And so the data is now being developed around depression, anxiety. There's data around obsessive compulsive disorder now by using these devices. But you don't necessarily want to be the center where the first trials are done. You may want to be the center where the second or third are done. And so we've kind of taken that approach and been conservative about it, but also where there's an area that's exciting and it really does seem like there's an opportunity to make sure we're positioned to be able to do that. And I got to say, for patients who may have been on 1, 2, 3, drugs for depression and had lifelong struggles with this, the idea that you can do a surgery, which is honestly a relatively benign surgery, and make a dramatic difference in their lives is really an incredible thing to think about. And so I anticipate in years to come, we'll be doing this kind of thing in our community based on what we've seen so far.
Great, thank you.
Sure. It should, the other thing you have to figure out is really what are the right centers to put these electrodes in, what's the right 3 millimeter, 2 millimeter, 5 millimeter spot, and how do you stimulate that? And those are the things that get sorted out in these trials. And so that's what's underway now.
I have a question, Molly. You talked about it's like you said, a pacemaker for the brain with people with Parkinson's. Like, how often is that used? My father has Parkinson's and he's pretty advanced. He can still walk with the walker, but when is that used? And I'm just really curious. I've never heard of that.
Sure. So DBS, or deep brain stimulators, are being used more and more commonly in Parkinson's disease. It's a surgery that we do, once a week, more than once a week.
Wow.
And so we have really, I think we may actually have the largest group of movement disorder neurologists in the Sound. Really, it's an incredible group who do the research around these devices and then partner with the neurosurgeon who does the procedure, who's a part of our group as well. And so it's the kind of thing, there are relatively strict criteria for when we do that and how we do that, and the programming, which is a whole other piece once you have that stimulator in. And that's why having a comprehensive center like we have is really important, right? So you do the evaluation, you say, you may not be a great candidate for this, but we're doing 3 research trials in X, Y, and Z. Maybe you're a better candidate for that. And we have, a big enough group of patients to support that kind of infrastructure, because
Yeah.
you want all those pieces in place, and it's exciting to be able to offer that.
Yeah. Are you seeing more Parkinson's patients? Just curious.
We are, honestly, we've had the Booth Gardner Parkinson's Care Center for years now in place. And what's amazing is that for many years, it was 1.5 docs, 2 docs, and now it's 5 busy docs. And so the incidence nationally has increased, and we've seen that locally as well.
Yeah. Okay. Thank you.
Sure.
There's a question now in the chat about concussions. Are there new treatments for concussions that reduce the harmful effects?
Concussion is tough. But I'll go on beyond just saying that. We are understanding more and more about concussion and the mechanisms. I think, our older treatment for concussion, which was basically, kind of shut yourself in a room and avoid any stimulation, seems like that's not the best approach. So really having a supervised return to activity is becoming more evidence supported as the way to do things. We have a multidisciplinary approach to concussion, and so it's frequently physiatry. It may include neuropsychology, and we have neuropsychologists on staff. The primary care docs are good at managing minor concussion, but I wish I could say it was an area where there had been big advance. It's definitely a really frustrating area, partly because I don't think we understand it super well. And the range of concussion is pretty variable too. The keys up front are to make sure it's not something that is dangerous in the short term and needs surgery or other intervention. And then one of the keys that we do know as well is that you don't want to have multiple concussions, particularly in a short period of time. And so avoiding re-injury is super important.
Wow. All right. Well, again, on behalf of all of us, Dr. Likosky, thank you. This has been fascinating. This has really been a terrific presentation, and I think I'll speak for everybody, we've all learned from what you've laid out, and I think the hope of promise of what's to come, and how you talked. I think what's very interesting is talking about how you are working, how the docs who comprise the Institute have been working together so well jointly, so that we're able to offer on a combined basis so much more to our patients. So more to come for all of you on this and other topics. We'll be following up with a post-event survey, so please let us know what other topics you want to hear about, in addition to any follow-up questions that you may have. We'll also be sending you later an email recording of this presentation if you want to share it with others who couldn't make it today. So again, thank you, Dr. Likosky. Thank you, Circle of Excellence members, for being here today, but most importantly, for all the support that you give us. You're helping us maintain our world-class status. So enjoy your weekends, everybody, and thanks again. Have a great day. Bye-bye.
Thank you.
Thank
you.
Bye-bye.
Thank you.